So we have this very important session on health and nutrition. I must share that, recently we did this report on rice fortification and things, and we were really trying to understand a few things about how health and nutrition are aligned or attached, or how they actually bring out economic outcomes and so on and so forth. But I'll not really delve more into it, but I'll request Richard to moderate the session. Richard, we have to catch up on time, and you have exactly 40 minutes, please.
You've got it. Thank you, Amit.
Thank you, Richard.
And thanks, everyone, for coming to the postprandial panel session. We're going to talk this afternoon about a number of areas on the social progress side that are extremely important to India and will involve structural change as well as just continued improvement along the vectors that the country is already moving. So if we talk first about health, India has a relatively centralized public health system that is insurance-based, but only about 37% of the population has any kind of insurance at all. And of those, the vast majority are insured by a public health insurance. And the delivery of health at the level of the local community is something that has real challenges and varies a great deal by region. In contrast, food is a relatively kind of distributed to the states. So the total value of India's public distribution system for targeted segments of the public is $750 billion a year. 30% of the grain output of the country is bought by the government. The purchase by the government is then bought at a subsidized price by the individual states. And the individual states then distribute it at various kinds of ways through, fair use shops or fair price shops, where individuals can buy grain at extremely, inexpensive prices. But the study that Amit talked about is an area in which these two overlap, because not only are people concerned about having sufficient calories, and there are still estimated to be about 190 million people in India who have some level of food insecurity, but it's the kind of nutrition. So the government has been fortifying rice and other grain with iron and with other nutrients, and this has had a good impact that it has had. But I think the real issue is, moving forward, how can India develop a much more effective way of raising the level of the population to kind of counteract the issues of inequality that we saw or that we heard about in earlier sessions? I'm delighted that we have a really good combination of people on this panel. So to my far left, Mukesh Bansal is the CEO and co-founder of CureFit. And next to me is Neeraj Jain, who is the country director for India for PATH. And to my immediate right is Dr. Anurag Mairal, who is the director of global outreach for the Byers Center for Biodesign inside Stanford School of Medicine. And furthest away from me is Mark Esposito, who is a faculty on Harvard Center for International Development. So we have a variety of ways to look at this topic. Let me just go from the far left first. So Mukesh, would you tell us more about CureFit and what CureFit does and what you're doing in this kind of general topic area?
Good afternoon, everyone. So we started CureFit in 2016. The idea behind CureFit was, can we build a platform which brings all aspects of health together? In health, the very broad way of looking at it is preventive health and curative health. Preventive, you try to do things so that, you don't have health issues to deal with later. You fall sick, then the curative, when you go to doctor and, get the treatment, etc. I think everybody in the health around the world knows if you can somehow enable people to have healthy lifestyle, you will have much lesser downstream issues. So whole CureFit was built around that idea that what can we do to encourage everything that's required for preventive health, from fitness, nutrition, meditation, sleep, even primary care. So we've been at it for last 7-8 years. Some part of business have worked really well. Today we are by far the largest fitness company in the country with 600,000 centers, about 750,000 subscribers, 2 million more subscribers for our digital platform, which enables working out and meditation, etc. at home. But it's work in progress. I think overall, I feel country as a whole need to do a lot more on the prevention side of things. So it's been 8 years for us, but I think CureFit and many other companies, including government initiatives, etc., together, I think can do a lot more to just enable awareness as well as empowering people to pursue healthier lifestyles.
So CureFit is essentially a for-profit corporation. And I'm curious how you see the innovation from the for-profit sector as having a big impact on health.
See, I mean, look, I'm wearing Oura ring here and a Whoop band, so I think there is no dearth of for-profit innovation where people can enable. Today, a lot of people are doing preventive tests. Again, there are a number of companies in US with all kind of diagnostic tests. You can order at home. So I think it depends on which part of preventive value chain you want to pick up. There is the consumers aware. I think you said postprandial session. India is considered diabetic capital of the world with over 100 million people with the some stage of getting diabetes, which is directly related to level of activity, movement, and nutrition. So I think private sector can pick up any of these areas and create products. I think there is demand. We are seeing in the FMCG sector, most companies are changing their product configuration, fortifying, all kind of snack with lot more fiber in it, lot more healthier nutrient in it, and all these can be solved for profit. So I don't think, there is profit motive. In fact, it's a good driver for innovation to bring, all these technology and solutions to people who are ready. I feel, India is, when we started 2016, for me, we talked to hundreds of consumers. And even back then, everyone's talking about multigrain breads and quinoa and, and so on. And these are, Maggi was shifting from this just pure, maida, which is, very refined starch, to atta Maggi and so on. So you see all these signs and see consumers are ready, they are looking for these solutions.
So if I can just support what you say about the importance of for-profits in this, for-profits operate under the condition that people want to buy what they have to sell. So the solutions that you come up with to a problem are solutions that will really be much more likely to be accepted by the population.
Absolutely, absolutely. And I feel very proud of what we do. I said 750,000 subscribers who pay us $200 a year, but in return they show up in our gym 3 times a week. So these are the large scale of people who are able to pursue much healthier lifestyle than they would otherwise, and they're obviously willing to spend money for this.
But for a different segment of this really big problem, I'm delighted that, Neeraj, you're with us today. Can you tell us more about PATH and what PATH does?
Sure. Well, thanks for having me here. Before I start, I just wanted to say that when I read about the topic and it said the elephant moves, I was reminded of an elephant with big ears that actually started flying, right?
Right.
And I think it got a very interesting name, which was given Dumbo, which kind of said, okay, that's not a very positive framing, but a flying elephant is what I think India is getting ready for. So very, very excited about what's happening. I work for PATH. PATH is a Seattle-headquartered not-for-profit. I lead the India work for them. We work in the public health space, nutrition, and been with PATH for about 8 years now. But I think, one of the most exciting things that has happened in India, and Richard, you did the report, is the way that India has managed to scale up the fortification of rice across the public distribution system. Fortification is known to be a very, very useful, tool to actually to take care of micronutrient deficiencies. And there's enough evidence out there that it works and it'll have huge impact. What the government of India has managed to do is to, from the launch of it or from the start of it about 4 or 5 years ago, today about 600 million people across the country are getting fortified rice in the public distribution system, which provide necessary iron, folic acid, vitamins in there. That's only possible in a country the scale of India. Everybody talks about the population of India being very large, the challenges around it, but there's a great opportunity because nowhere else in the world can you scale something the way you can in India. You've got this huge population, 800 districts, each district has about 1.8 million people. What has happened in the process is that in the last 2.5 years, from about 5 million tons of rice getting fortified, we're at about 50 million tons now. And the target audience is people who can't afford the necessary micronutrients, the necessary energy levels that they should be getting. So this is an absolutely...
If I put that in context, that's about half of all of the rice that's distributed through the public distribution system, right?
We are at, actually, in terms of the public distribution system, we are at about 70%.
Okay.
We're at about 70% of the rice is getting fortified, and we will hit 100% by the summer of this year. So it's a program which has just got scaled up. Just to give you an idea of fortification is actually present in about 80 countries. And the second largest such scale-up would be about 100,000 people. So that's the sort of difference that we're talking about, 100,000 versus 600 million where we are today, going to 700 in the next few months.
And PATH as a nonprofit, but not part of the government, what is the role of your organization in studying monitoring the system or what?
So, PATH started working on this about 15, 20 years ago, started from the US, we did some work in Brazil, etc., but really creating the evidence that's necessary to be able to roll out something like this, looking at the supply chain, doing the economic analysis, the entire sort of evidence that went into it is where we support it. This program is totally government funded, so PATH does not fund this program. It's absolutely government funded, we only provided technical support. Currently, we are setting up the largest digital quality system for this fortified rice, which is going to really cover the entire spectrum of all the rice in the PDS, and look at traceability, because quality is going to be a large issue. A large country, well spread out. So that's the kind of work that PATH has been involved with.
Okay, thank you.
Thanks.
And Anurag, from the standpoint of global public health, what's your perspectives? Tell us a little bit about your center at Stanford and what's your contribution to this area. What are your interests?
Absolutely, Richard. And first of all, thank you for having us on this panel. Great panel. I followed Mukesh's work for a while. I was part of PATH, and I'm a big champion of what PATH does. And of course, I've known you since the last year. The work that we do at Biodesign started in India, started about 17 years back. Stanford Biodesign is a design thinking-based approach to health technology innovation. It's a program that started about 22 years back. First, it was in the US. In 2007, we decided that we were going to take this global. And the first country we chose was India. It was in partnership with AIIMS and IIT Delhi, and Department of Biotechnology was part of it. They supported the India side, and we supported on this side. The goal was to bring innovators from India, train them here, and then send them back so they can come up with the innovative health technologies for India's needs by Indian innovators in India. That program was small, 4 fellows a year and 1.4 billion people, 1.3 billion at that time. 17 years later, there are 1,000 innovators in India, 900-something innovators in India, 300 companies that have come out of it, 75 or so commercial stage companies. So India has really traveled quite the distance. It's really flying. Elephant is really flying. And it has led to substantial impact already, but I think it's just the beginning. If you look at the number of lives that have been touched by these health technology innovations, and that's, you're talking about, how India needs to switch its structural design of healthcare, as well as it needs to actually do things better, better processes, better outcomes, and so on. And I think these innovators and the innovations that they come up with could be the basis for flipping the healthcare system. Most of the healthcare systems in the world are tertiary care centric. Anytime you have any serious condition, you end up at the tertiary care. But India has an opportunity to flip that and bring healthcare closer to the home and the communities through ASHA workers, through A&Ms, and health technologies can help them do it.
So what do you think is the biggest challenge for India in moving to that flipped model?
Yeah, well, there are 7 or 8 categories of big challenges.
Okay.
India is a big country and challenges are big as well. I think talent is one piece of it, which is what we try to address through Stanford Biodesign's work in India. The second one is really the framework. So even though there are a lot of these innovations that are coming out of India, most of those have not been adopted in the public health system. They've been successful in the US. Those same innovations have been successful in the US. They've been successful in the private healthcare component of India. And many of these technologies have gone on to serve 30, 35 countries, but it hasn't yet made into the public health system. So the processes and the frameworks for incorporating these technologies in the public health system, that's actually a huge challenge. In fact, and as you correctly pointed out, health is a state subject. And it's important that each of the states actually take this on and then they do this in sync so that an innovator doesn't have to go to a state 1 and then has to go to state 2 and sort of keep having to prove himself or herself with that technology. So that, in my opinion, is one of the biggest challenges.
Okay, thanks. And moving to that, then we have Mark to talk to us about international development and your perspectives of the situation in India and how it can move forward.
Great. First of all, thank you for having me. It's the second time I'm here in the India's Dialogue, and it's nice to see many familiar faces, new ones. And maybe a context why this conversation is important. About a year ago, I started to work with the United Nations on a digital public infrastructure project as part of a fellowship. And that's when I joined the Center for International Development at Harvard Kennedy School, where it's within one of the 3 areas of attention that the center is bringing forward. One of the things that we see a lot in digital public infrastructure is the conversation on how we disintermediate transactions to make governments or government processes more agile. We're improving the sense of governance, but there's a clear understanding that there is an economic driver that will simply create more efficiency. What is sometimes missing is the conversion about digital public infrastructure in the enticing mechanism for health and nutrition. And there are examples that we studied from outside of India that came from India that show that the private sector that is now advancing. There are a couple of examples that I'll bring forward. One is historical. It was a company that was using a mobile banking to educate slums to how do we use the right choice of food for families that were on the poverty line. And the other one is one side of the story where we use technology to basically empower families in highly concentrated slums. And the other one is an example of a company called Neeraj being developed by Google as well, where we're using basically AI scanning for the detection of breast cancer for women under the age of 40 when mammography usually is not that effective. And these are 2 examples coming across the field that shows that when we're thinking about digital public infrastructure, we shouldn't only think about public, but whether the public infrastructure is now servicing a much wider sense of opportunity that are across the chain. And I think this is where, in terms of international development, a closer nexus between DPI, health and nutrition has to be established. Otherwise, it goes back a bit to the work Michael has been going on for over a decade now. We tend to be comfortable, we do bromancing with economic narrative, but we forget that the right form of economic growth is when you are using social driver to create economic opportunity, and health and nutrition are some of the most fundamentals to do that.
Okay, thank you. Those are great comments to start with. I think I get to ask one difficult question to the panel, and then we'll open it up to the audience. So my difficult question is, where do you want to see your organization and also India, where do you want to see them being 10 years from now? And I'm going to start with Mukesh. Yeah.
See, at CureFit, our core focus is fitness. Today in India, we have only 6 million people who go to any kind of gym out of 1.4 billion. So that's just what 0.4% of the people. I think in preventive health, everybody knows that activity, movement is really important. And India is a place, which invented yoga, I think, few thousand years ago, and probably a lot more people outside India who practice yoga today compared to people in India. So that needs to change in next 10 years. So I think, before answering CureFit, I think, at CureFit, we have defined our mission that we want 100 million people to be active every day. CureFit can do very small part of it. So I think we'll do what we need to do in terms of expanding our footprint and so on. But we'll also like to work with the other players in the ecosystem, including government, to just promote awareness about movement. In US, I think, Michelle Obama had this very, popular campaign around movement. I think India needs something similar to that. So yeah, it'll be great to go from 6 million gym goers to 100 million plus, and they don't need to go to gym, walk, yoga, run, cycling, any kind of activity is great, good start for good health.
So I got to follow up. Do you think that as income levels increase in India, people will have more unhealthy lifestyles?
Oh yeah, 100%. There is, I think there are a lot of economists and social scientists in the room, probably they can comment more objectively, but I think anecdotally, people call it, disease of lifestyle, or there is an also acronym. I think something like, I don't know, standard American diet, SAD, right? So I think, yeah, affluence has been growing in India, and therefore number of McDonald's establishment and Taco Bell and Pizza Hut also, growing up everywhere. And I think, there is a very direct correlation of obesity rates are increasing, diabetes rates are increasing. And I think India will have to contend with that, or better still, learn from the history of the, other developed country who kind of went through similar cycle. We have all the data. I think we talked in other sectors in the morning. So we can learn from that and try to prevent that from happening. That's where I think proactive policy, etc., and just consumer evangelism and awareness can play a big role. So we don't need to, first get all the way there and then, create a whole healthcare system to be able to deal with the, highly preventable lifestyle diseases.
Okay, thanks. Neeraj, where would you like to see PATH in 10 years? And also, how would you like to see the situation in India?
Yeah, I would like to see PATH exiting India. I don't think we should be there after 10 years. So that would be ideal. But I would really, there's a lot of expectation from the health system in India. And the two areas that, I want to just focus on, and those are the two which we think are going to make the maximum amount of impact. One is in the primary healthcare space. So you might have heard of health and wellness centers, the whole primary healthcare, the entire ecosystem is changing. The policy is all there. We do have to implement, parts of it is getting implemented. So if that gets implemented the way it's been written, I think that's going to be a huge success for India. And we are on our way to do that. Now, within that, it's about diagnostic, right? So if people walk into a primary health center in the middle of Bihar somewhere, they get the initial diagnosis, they get escalated. So are we diagnosing at the primary health care facility? That's getting set up. Every block, there are about 7,000 blocks in India. Every block is getting a laboratory, a public laboratory. Every district is getting a laboratory. That's about 800 districts. So if that system starts working, to me, that would be huge success. And it's been written really well.
But especially with the shortage of healthcare professionals, do you see this as a real opportunity for telehealth?
So that's the second part of what I want to see. We're going to have the challenge of healthcare professionals is going to remain. The challenge of population-level health management will require technology. And that technology is going to come in multiple forms. And a lot of it is actually getting rolled out as we speak. So for example, there's this digital public backbone that's been set up, the Ayushman Bharat Digital Mission, which has open APIs, private companies can connect onto them, etc. So that's getting rolled out, and we're getting individual ABHA IDs. These are Ayushman Bharat health cards, which you have a number, a unique number. So the electronic health record system is getting established. Now, so that's the digital side of it. Telehealth already has been rolled out to a great extent, but diagnostics which are connected. Is where we would go. Diagnostics which are very simple to use, a frontline worker can use them, and they go into a system where they're getting analyzed. We're already doing cervical cancer screening through AI in public health facilities in India. That's starting up. breast cancer screening for tuberculosis through chest x-rays, screening for lung cancer. So, this whole technology piece is being tried out in different places across the country, but this is going to be the game changer. We will have to use technology to be able to do that. I think just want to quickly also talk about something which got launched during the G20, the Health Working Group in India, which is the Global Initiative for Digital Health, which is a South-South kind of a partnership, platform, which is going to provide low middle-income countries with funding to go digital. I think the realization, Richard, is that without digital, without technology, most low and middle-income countries, not just India, but across the world, the entire global South, is not going to be able to leapfrog their healthcare services.
Yeah.
So India has this opportunity also to lead on some of those conversations, and that's the excitement here.
So I really have to ask if Stanford Biodesign picks up on this.
Yes, so in fact, that's a great segue to my comment that two things I would love to see in 10 years. Number one, that India has transitioned to community-centered care through technology, through ASHA workers, last-mile workers, that will actually obviate the need for 10 million more doctors or whatever we may need. So more community-centered care, more home-based care. 80% of the conditions caught at home or near home, so that only 20% or fewer conditions actually need to actually go on to secondary and tertiary care. If India can get to that, it can actually provide healthcare to its 1.4 billion people at the rate it's spending on healthcare. So that's number one. And second thing that I would love to see, again, building on the point that you made, Neeraj, is I would like India to do the same thing with health technologies that it has been able to do with vaccines. Become a net provider of innovative health technologies and this model, community-centered care model, to rest of global South. There are 5 billion people in the world that don't have meaningful access to healthcare. In this day and age,
what's the role of kind of
Biodesign?
Innovation in this regard?
So I think you cannot bend this cost outcome curve. We spend 18% of GDP on healthcare. Europe spends 10%, considered to be gold standard. India spends 2.5%. There's no way India can get to 10%. So the only way India can provide, India and Africa and Latin America, all of these regions where substantial proportion of underserved populations live, the only way they can provide care to all of their people is by bending the cost outcome curve. And there's no other way to bend that cost outcome curve other than innovation.
Thank you for setting up international development. Mark, your comments about where India should be in 10 years. How to fund this.
There's a whole plot I can feel here, right? So my wish would be to really, maybe let me give you a premise. Countries like India are the forefront of climate change. If there was a theater, they would be sitting on the front row. And so they have an exposure to challenges that other countries might eventually feel at a later stage. So I would love to see more research on how, while we're transitioning, we're also climate adapting and mitigating with the right level of technology and understanding the impact on agriculture with the changing climate. Let me try to give an example. With a significant rise of temperature, the number of proteins, for example, in rice, they decrease, which means people will need to eat more but have less actually protein in their body. It might actually likely lead to overeating because we're trying to compensate. So on one side, we might want to see this as a habit or as a cultural norm towards a healthier style, as it was mentioned by Mukesh before. But it's also true that there's a significant amount of work in the science on how climate is fundamentally going to impact agriculture. I'd love to see more work in this nature. I'm going to give you an example. I was doing a training for policy in Qatar. This country was in a blockade through the region from 2017 until 2021, and then, of course, COVID did not really help. And it's a country that was importing 100% of agriculture from Saudi Arabia. Within 4 years, they have boosted up their vertical farming capacity to the point that when you go into a supermarket, as they in Qatar, half of the agricultural produce are vertically farmed. And this is a country that has hostile agricultural conditions to grow food. So I think we have to learn from the adversity to drive it into some form of innovation capabilities, which are dynamic, as we're doing two things, transitioning and mitigating at the same time. And I think the country, because I've been hearing the celebration on how technology is fundamentally changing payments and the financial sector. But wait some time, we should consider that this is maybe a driver of spillovers that might go into health and nutrition as well.
So lightning follow-up for everybody. How do you see the inequality that is resulting from India's economic development affecting this? Because a lot of the health problems, a lot of the nutrition problems are those areas that have not developed.
Absolutely. And so look, one of the things where the social progress help us a lot, if you're looking at this in terms of also the opportunity for people that are in a more progressive or less country, is also life expectancy. Right? In country with larger inequality, and I remember when I think it was James who was talking about the billionaire Raj, when you're creating this structural inequality that are difficult to eventually decompress, likely what you're going to have is the inequality that doesn't express itself necessarily just as economic inequality, but lifestyle inequality, life expectancy, food inequality. And so I think one of the ways for us to curb the tendency for system to become unequal is to provide a larger threshold on conditions like health and nutrition. So I think if we do that, then equally the conversation on inequality from an economic perspective can be curbed. So I think they're very intimate. Is that historically they're studied in silos that tend to be vertical and not transversal. And I think what we have to see is a country building transversal or interoperability across all of these different kind of R&Ds.
Okay, excellent. So anybody else on the panel have comments about anything so far? Otherwise, let's move into audience questions. So have a hand up back in the back, and then I see the second hand right here. And several, okay. You first.
Just one question for the larger group. What are some of the things that you think like ABDM can learn from platforms like CureFit? And also, do you kind of foresee any potential for a market-based solution catered to like low-income communities?
Catered to what kind of community?
Low-income communities.
Okay.
Market-based solutions like a CureFit or things.
Sorry, ABDM is?
Ayushman Bharat Digital Mission.
Okay, Ayushman Bharat, yeah, right. Yeah.
Mukesh, that's yours, yeah.
Yeah, I think, see, again, I'm going to answer this more from, preventive point of view. And when your prevention requires, some kind of behavior change. Behavior change is very, very difficult for people. All of us struggle to make that change. And the only way to do that is to remove as much friction as possible and also have right kind of incentives. So a platform like Ayushman Bharat Digital Mission, I think while it's great that so many people are covered through insurance and something goes wrong, then there is a net. But I think if we can also layer on a lot of proactive communication and incentivization, I think the insurance globally around the world is moving the direction where insurance providers are trying to incentivize preventive behavior. You do your 10,000 steps, over a period of time your premium will go up. You connect your digital watch, and so I think ABDM can also consider some such initiatives to just encourage. I think I want to go back to also inequality. See, on the cure side of things, there is massive inequality. You have a advanced diabetes or cancer, you can only go to really good hospital, you get good care. But prevention is very cheap. It does not cost anything. 2 years ago, I wrote a book on health. It's called Hacking Health. It's a 100,000-word book, but I summarized the beginning that the entire message of the book can be just 6 words, which is eat less, sleep more, always move. All 3 are free. Anyone can practice it. It doesn't matter what your income level is. So.
Thanks, Mukesh. Anurag, you had a comment.
I think that can apply. All 3 of those should apply to me. But I'm going to build upon the point that you raised earlier. What is the role of innovation? I think the underserved community, lower economic communities in India are the ones that are most impacted by the structural inequity, and that's going to get worse. And it's a vicious cycle. Health and nutrition go hand in hand with overall inequity. And if they are worse, then actually they get into the death spiral, these communities. Innovation can help it. And so Ayushman Bharat Digital Mission is a really interesting digital public infrastructure on which you can have really significant at-scale interventions that not only enable the last-mile health workers becoming quote-unquote doctors, which is the example I provided, but it could also do communication, health communication around better lifestyle, better food habits, and on and on. So I think that gives an opportunity to, again, I call it flipping the pyramid in terms of the health equity and health access.
Thanks. We'll go on to a question over here, and I saw a hand. Your hand was the first one that I saw, so please bring the mic over here, and we'll keep going around. Go ahead, please.
And my question is to any of you who wish to answer. Private sector, especially for bridging the health equity, can play a very essential role. We have seen experiments in the TB partnership, which was done in a very systematic manner. Unfortunately, the experience in the ground has been very frustrating for a lot of organizations who came forward. So I request you if you can give some suggestions in terms of how we can create an enabling environment for PPP in the country, because the kind of scale we have, it cannot be just met with public sector efforts alone. And second is, especially when we talk about universal healthcare, private sector does have a role to play. At the same time, there is a need for bringing in regulations and all, especially when it came to the digital health policy, and it was pulled back because there was a lot of hue and cry about it. At the same time, I have heard in bureaucratic circles people saying that, oh, don't think that we are Africa, that anyone will come and take our data and just play around.
Okay.
So I think there are very, very genuine, serious concerns around it. So I just want your views on that.
Thank you. Neeraj, why don't you take that?
Did you talk about the TB program? Okay, but that's great because we were very much a part of that whole private sector engagement.
Yeah, the BMGF report has you also as one of the partners.
Oh, it does? Okay, great. That's good to know. So, yeah, we started that program in the Mumbai slums. I think there is definitely a role for private sector. The challenge is, what are the incentives? Because, the private sector will definitely look at some sort of a gain, financial gain, whereas public health goes actually against that whole thought process of providing services to those who can't afford it. Having said that, I think the intersection is going to be absolutely critical. I mean, if I were to just look at our whole vaccine industry in India, which is now, 60% of the world's vaccines are coming from India in terms of volume. The reason it's been so successful is because they have different pricing for public health versus the private sales that they do. And that's how it's been able to succeed. Now, in terms of universal health coverage, I don't know if you know, but India, till about 3-4 years ago, the data used to show about 70% of India went to private healthcare providers. That has been going down. Mm-hmm. Exactly, I was just going to say. So it's been going down substantially, and which is great for the country. Yeah. Because that essentially means people are starting to trust the public health system, starting to use it more. It's always going to be a combination of public and private. I don't think there's there's going to be either or, but we do need the public system to work, and that is why these public laboratories, et cetera, are going to be absolutely critical. On your point of regulation, quickly, Richard, if you'll allow me, yes, when we were working in the slums of Mumbai, the challenge was many unregulated private practitioners who were providing services. And that actually was aggravating the problem of tuberculosis because you were getting drug-resistant TB, et cetera, et cetera. We need the carrot and the stick approach. In the TB program, we had the carrot and stick, and that's how it's going to move forward. But yes, we do probably need much stronger regulation, especially for practitioners who are practicing without any kind of, we call them the quacks, but that's definitely a challenge.
So also, just to pick up on this, you mentioned the ASHA, and these are local health workers who are essentially public employees. And so I think you have a similar kind of incentive problem where they need to feel like they're taken care of. They need to feel like people understand their pressures so that they will do their jobs and not be absent on the job.
Indeed, absolutely.
Yeah. Absolutely. Yeah.
So, please.
Really, we heard something very fascinating on diagnostics and prevention. I wanted to see if there are any big ideas on, because drugs and hospitals are a big part of this whole equation. Are there any lessons on the cost of drugs, overuse of drugs, drug regulation, and same questions related to hospitals? So how do they fit into this whole narrative, and if there are any lessons/ideas that you would like to share.
Mark?
Sure, I can share actually an insight from a discussion we're having 1 year ago in this room. So COVID has created the bioscience clusters in India, which means you're repurposing the manufacturing capacity for something that's much more contemporary than just manufacturing per se, because somehow the demands globally changes as we're going through a cycle of different crises. So I think the opportunity would be to recalibrate the current capacity for the rise of new forms of cluster, and drugs, of course, is one of this. The other part which is interesting is how do we use research and development? There are a number of different initiatives right now in the country to start understanding from a perspective of prevention, disease that will actually occur as an evolution that we have been exposed to the climate. There's an entire amount of work on climate-resilient diseases that we're not addressing. No country has the scale to address it but a country like India. In the same way as when we celebrate the 2.2 billion doses of Pfizer that were administered during the COVID, what really it proved is that if you find some sort of like logistical nonlinearity that makes it work, you fundamentally can do what most countries can do, which is scaling. So there's almost like a moral principle around the fact that India has to start advancing through the cluster on climate-resilient diseases. I think this is an opportunity the country has. There's no competition right now globally by anybody. Just as a reminder, the vaccine are a direct spin-off of the DARPA investment of about 10 years ago. So it was a military technology that eventually got commercialized. India can operate out of the same principle where R&D goes in military, hoping they get commercialized, like it has happened in the conglomerates in the United States. So he has to follow a slightly different approach, which is likely following the wind of change, where the country is exposed to the Southeast Asian dynamics, the relationship with the Gulf, a relationship with the West, a relationship with the East, and a relationship with the North. So I think it's fundamental where India has a role that can move forward, looking at the example of what happened before, and moving forward in what will actually be the policy in the next few years.
Neeraj, do you see the pricing difference between public purchasing versus private sector purchasing for drugs being sustainable in India? How do you see that?
Yeah, Richard, I mean, that's why I said that the public and the private will operate in parallel. I will probably, I don't know how many of you have ever been to a government primary health center, but typically when I walk into a room, most people haven't. So, there's always going to be two different markets. There is regulation, which is in the private sector, which is there. In the public system, I can tell you that we are working with 6 states in India to actually reinvent the entire supply chain. And our partner in that is a company called Tata 1mg. So they're sort of the gold standard in the private sector. So we're kind of saying, help fix the supply chain and the procurement processes. But they will always operate parallel. They will be purchasing from the public to the private. That's going to happen. And I know a lot of hospitals are very, very unhappy about the pricing that has been set up. But that's the pricing. And the government has done enough homework to come up with that pricing. I think the challenge is that a lot of payments don't happen on time, and that's something which sort of troubles the private sector at times. So that we need to fix probably as we go forward.
Thank you. Next question.
Question on actually payment. So India is typically, even now, a self-pay model, right? If somebody wants care, they have to go and pay. Will India eventually move from the self-pay model to a more sort of coverage model like other countries? Is there something you're looking at? And how would that also be related to value-based care? That's also something that India is not looking at. So those are the 2 questions.
Sorry, go ahead. Who wants to take? I'm sorry, I was distracted trying to find the next person to ask a question.
I couldn't really understand. You were talking about the self-pay model. Are you talking about insurance versus? Not if you go to a public health facility, it's all free.
Vast majority still go to private.
About 50% of India goes to private.
More than 50%.
It's going down, though.
Yeah, it's going down.
It's going down.
It's probably more like 65, but based on our analysis. But what I'm saying, would that model change over time, given that India is trying to progress and move to a more coverage-based model for private citizens?
So if the quality, if the quality in the public health system is going to improve, and that's what's been happening, the quality has been slowly improving, then it will change. If you know Delhi, for example, if you talk about All India Institute of Medical Sciences, it's one of the best places to go. And even people who are happy to pay are, they would like to go to AIIMS if possible, because services are great. The only problem is that there's a bottleneck, there's too much of a crowding there. So as public health facilities keep improving, that would change. In parallel, of course, insurance will come in, but I don't think you're going to see a drastic change in this whole equation.
Come in and start.
Yeah, if I can just add to that, right? I think the data I was looking at recently is in the hospitals. Now more than 50% of the payments do come through insurance. This is definitely true in the big city hospitals, and this ratio is changing every year because even the private, look at any company, any multinational, all the employees have health insurance. Now coverage obviously not very wide, but these are people who go to some of the mainstream hospitals. The challenge with the insurance so far was that in India, the model was only inpatient care was covered by insurance. So you need to be hospitalized overnight for a day treatment, that was not covered, which leads to a whole different set of issues. But leaving those aside, now a regulator has enabled OPD insurance as well, and many startups are attacking that. Existing insurance players are also getting into it. Some of the hospitals are thinking of becoming, HMO-like model. So I think this whole space is moving. I think it will obviously not happen overnight, but we'll see the coverage both through private efforts and public effort, I think grow significantly.
And I would just add one very quickly. I would caution India against following the models that have been applied elsewhere. The insurance model doesn't work very well in most of the other countries. India should figure out what works for it. And in my opinion, I think the shift that's taking place where more care is being provided at public health systems, and Ayushman Bharat insurance program, which covers 500 million people, 100 million families, all of that combined with increase in adoption of private insurance that exists today is probably going to address that. I don't think we should lockstep move into completely private insurance-driven model because that's going to be disaster for India, in my opinion.
Thank you. We have time for one more quick question.
Yes, thank you so much, Richard. I just wanted to pull out just a shade from the many things and say that human health is such a huge element, and if you look within the health, you can almost, go human health and resilience, which the UN and, Helen Clark, and there's been a lot of conversation about that. And education is another element which is part of health and resilience. So I wanted to ask a question. Environmental education in India, I know the EEP, and there have been many, many initiatives, but personally, I don't see a kind of a cohesive, integrated element, which is so essential for a country at the scale of that level, and also not just a kind of education from the top, like this is what's happening, but education as a stakeholder, each individual child, adult as a stakeholder. What can you do? What would you do? And just really quick, and also how do you, fill the innovation pipeline with this situation, not just from the resilience point of view, but also from a thrival point of view. And then, so I think those are some questions that occurred to me. I would love to see, like the Climate Corp has added a few 70 fellows in there, but how can we make the entire country a Climate Corp?
Thank you. I'm going to be mean and throw that question mostly to our panel on education that's later this afternoon. It's certainly the case that one of the key points is to come up with integrated goals for education. How do you define literacy in a place like India, where environmental knowledge as well as knowledge of health is certainly critical parts of any education system? But if you're worried about the fundamentals of FLN, foundations of literacy and numeracy, then maybe those things get lost. It's a danger. I hope we can come back to that later this afternoon. So thanks to all of you for staying awake during our panel. And we really appreciate it. Thanks to the panelists.
Good to see you again. Yeah.